morning, good morning, good morning. It is 8 o'clock, so it is time for another educational session brought to you by the Department of Continuing Medical Education. I am so pleased to have you join us this morning. We have a wonderful program set up just for you. Before we get started, let us do as we usually do and open in a word of prayer. Father God in heaven, we come before you this morning, thanking you so much for another beautiful day that you have provided, another beautiful opportunity to learn, to build our craft, to build our skills, to build our knowledge, to be able to use it to the best of our abilities to help the patients that we serve on a daily basis. We pray, oh God, that you open our minds to receive the information that will be provided. This I pray in Jesus' name. Amen. This morning, we are having a special topic brought to you in recognition of Stroke Awareness Month. And our presenter, for those who may not know, I will gladly introduce her to you. Dr. Lia Franco is a Neurocritical Care Fellow at Stanford University, where she also serves as Chief Fellow. Originally from Ecuador, she earned her medical degree from Universidad San Francisco de Quito before completing her neurology residency at Tulane University. During her training, she was selected as chief resident and received awards for humanism and excellence in clinical education. Next year, she will advance her expertise as a neurointerventional radiology fellow at Oregon Health and Science University in Portland. Passionate about global health, Dr. Franco is dedicated to improving access to high quality stroke care worldwide. So this morning, it's a pleasure to have Dr. Franco presenting to us on updates in inpatient ischemic stroke management. Please, let's welcome Dr. Franco.
Good morning, everyone. Thank you so much for the invitation. It's an honor to be here. I will present to you as before about ischemic stroke care. I hope everybody can hear me well. Let me get sharing my presentation. Let me see. Here it is. Okay. Give me 1 second. Can you see it well? I hope you can see it well. Well, good morning, everyone. Once again, thank you for having me here. I will be talking about the inpatient ischemic stroke care and all the updates, the recent updates, and how we manage ischemic stroke in our units. As said before, I am originally from Ecuador. I am a fellow right now in neurocritical care here at Stanford, where my training involves a combined, it's kind of like a combined fellowship that includes vascular neurology. We take care of a lot of patients with ischemic strokes, combined with the vascular fellows, as well as their management inside the neuro ICU. That's where the main focus would be for me. I have nothing to disclose. And the learning objectives for today's talk is to be able to recognize the clinical presentations of ischemic strokes. I'll be touching based on some of the difficult cases that I recently had in the last week that made me doubt whether it was a stroke or not, or at least it made some other doctors doubt whether this was a stroke or not, and caused probably some delays in care. We're going to understand the relevance of imaging modality that are required for the diagnosis and management of acute and subacute phases of stroke. The indications of systemic thrombolysis, this is going to be the really important part, and updates on inclusion and exclusion criteria, when we can bend the rules a little bit for certain patients. Understand the impact of mechanical thrombectomy for large vessel occlusions. I will explain also the importance of the stroke etiology and secondary stroke prevention, and a little bit more about where do I think the inpatient stroke care research it's going forward. Before I continue, are you guys able to see my slides normal, or is it in presenter view?
It's in presenter's view currently.
Okay, let me fix that because otherwise it looks ugly. Okay, hopefully that's better.
Yes, thank you.
Wonderful. Now, the terminology that I'll be using is the National Institute of Health Stroke Scale, the NIH, the MRS, the ranking scale. We'll be talking about CT perfusion. I'll define exactly what this is later. LVOs will be my large vessel occlusions. The systemic thrombolysis will be for TPA, TNK, and anterior and posterior circulation is just a reminder of the anatomy for those that are not neurologists and not thinking about the anatomy frequently. The middle cerebral artery, MCA, or anterior cerebral artery, ACA. But posterior circulation, we think about vertebral, basilar, the posterior inferior cerebral artery, the anterior inferior cerebral artery, the SCA that I'm missing there. Now, why do we need to talk about this? Why is it so important to discuss stroke, and why we give it a whole month? Because stroke is the second leading cause of death in the world. It's the leading cause of long-term disability in the US. And in lower to middle income countries, is about second to third. It always goes up and down and fights its place with COPD. And the incidence in Latin America and Caribbean countries is rising. For a while, it was dropping. For now, in in the later years, keep going up from 90 to 120 cases per 100,000. This we see likely because of the aging of our population and increase of the cardiovascular stroke factors. In the global burden of disease study, 90% of the global stroke burden was attributed to modifiable risk factors, which is huge. We can change all of this with maybe modifiable risk factors. But the thing about stroke is that it's extremely dependent of the systems of care. When we read all the guidelines for the management of stroke, we can see that they make a huge emphasis on the pre-hospital care. And this is where the awareness is for the in the population. It's somebody noticing that they're having a stroke. Are they acting on it? In the US, a lot of people are very aware of what a stroke is. But in other places, nobody is. They go into the hospital 1, 2, 3 days later, or maybe a couple of weeks later saying, yeah, I couldn't move that arm, but it got better. It's fine. We need to be able to improve also on the emergency evaluation is, okay, you're having the symptoms, but who is there to help you to be able to give you take you to the appropriate place for care? The emergency treatment. The emergency treatment, there are only two options here. Number one, TPA, TNK, thrombolysis, or mechanical thrombectomy. Be able to access those two has made a huge difference on the outcomes of patients. And after that, the management of those patients in stroke units. Since the 1990s, we know that the stroke units improve stroke outcomes in these patients. Now, a little bit about the pre-hospital care. When you read the guidelines, the American Heart Association guidelines, they give you these severity-based stroke triage algorithm for EMS. And it might be applicable to a lot of the places here in the US, but not necessarily in other countries. Like in my country, yeah, you could teach the EMS how to identify it. Yeah, that can be done. But the problem with these algorithms, that needs to be adapted for each region according to the resources that are available. And here, EMS is able to identify are they having a stroke? Is it a big stroke or a smaller stroke? And which hospital should I send the patient to? Back in New Orleans, where I was before in residency, EMS used the scale, used the VAN score, where they identify whether the patient has higher likelihood of having large vessel occlusion, and by so they would take the patient to a thrombectomy capable place, or also not a comprehensive stroke center. And once they got there, these are the general guidelines that the institutions try to meet. They need to be able to be evaluated by emergency physician within 10 minutes of arrival. In less than 15 minutes, the stroke team needs to be there. In my case, it was the residents are there. In most places here, the residents are there to be able to evaluate the patients within 15 minutes. 20 minutes for imaging. Most places going to be a head CT. In places like UCLA that are places of stroke excellence is an MRI. In France, they do an MRI immediately. That's certainly not achievable in most places of the world. And in less than 45 minutes, you should be able to interpret the neuroimaging with 60 minutes to give TPA. In a lot of places, and I remember the second year fellow, I was able to give TPA within 6 minutes. Is that safe? Probably not. I'm not that fast anymore, but those are the general goals that the guidelines have stipulated for the inpatient management. And this is just averages. Now, how do we know our patient's having a stroke? It's probably easy, right? You just see the patient is losing some movement. Most patients, that's what they report. It's an acute loss of something. It cannot be a gain of something. And by that, I mean, it's not, oh, half of my body is tingling. That's a gain of a sensation, how my body is moving. That will be extremely abnormal and not typically what we see. It is our role to be able to say it's an acute onset of such symptom. And it could be motor, sensory, speech, vision, eye movements, and coordination. Those are the six areas that are most important to evaluate whether a patient's having a stroke as a true emergency. For example, if a patient comes into the ED with low blood pressure, we rush, right? The patient is in shock. We need to resuscitate the patient. The same comes with a stroke. You need to be able to characterize exactly when things started and what are the deficits. You can take some time later on to see, oh, okay, tell me more about this. And I like this graph that was published in Neurology, the Green Journal, about the localization of the lesions to make you think about, oh, is this located in such area of the brain or other areas of the brain, which we probably all studied in medical school, but it's hard to remember if you're not doing it daily. The most important ones to remember is the middle cerebral artery, which will give you weakness and loss of sensation in the other side of the body. That's the easiest thing to remember. It could be left-sided weakness or it could be right-sided weakness. The sensory. Sometimes it could be just the leg or it could be arm and leg. If it's an ICA, the internal carotid artery is gonna be arm and leg. Sometimes it starts with one, the other. The eyes will look towards the stroke. For example, in the left MCA stroke, the eyes will look at the lesion. The eyes will have a left gaze deviation, and that's different from a seizure. When it's a basilar, a posterior circulation stroke, it's a lot. It's harder to identify, and that's where a lot of patients get missed. Not all basilar occlusions come in fully quadriplegic comatose. Those patients are the ones that actually get missed because they had a cardiac arrest or they fell. They are admitted by other services. Sometimes it's just dizziness, vertigo. The important determining factor here is the onset of symptoms that persist in a longer time. Now, once we see these patients, we're going to get a detailed medical history. Yes, absolutely. We want that. We want to hear everything about them, but we want to do it extremely fast. Because remember, we have those 15 minutes, and we need to get them to a scanner as soon as possible. If the stroke started in the last hour, 3 hours, 4 hours, if they're within the window for treatment. We want to know the last known well, and this is tricky. The last known well, a lot of patients said, "Oh, the last time we saw him, well, it was on 4 days prior," but the patient can tell you, "No, but I know my symptoms started an hour prior." The thing about the last known well is dependent on the witness, and sometimes we don't have that. A lot of our left MCA strokes, they're aphasic, they're awake, they're aphasic. They can tell us that the symptoms started 30 minutes prior. So it can be tricky. We want to assess the modified ranking scale, which is I'll show you after. What's their baseline? Do they have any symptoms from some form of disability, or it's somebody that is already quadriplegic? We want to know if they had a recent trauma, radiation, any drug use, and the vascular risk factors. All of this is given by the EMS as soon as they arrive. Yeah, the patient has hypertension, diabetes, heart failure, because family or somebody next to them has told them already, yeah, the patient has this. And one thing that is really important to be able to rule out is knowing if the patient rule out if this is a stroke or not. Does the patient have migraines? Has the patient had this before? It's extremely important because the patient with migraines can present as a stroke. They look exactly like a stroke. Um, in some instances, the difference with migraines is that symptoms can travel compared to an acute abrupt onset. So we go to an examination of the patients and we use the NIH stroke scale, and this is a level 1 recommendation from the American Heart Association. This is common communication around the world of the symptoms that the patient is having. You don't need to be an expert on neurological exam that comes with so many caveats. I've done this for many years now as a trainee, and every single attending can examine the patient in different ways. You don't need to do that. This is a gross examination of how the patient presents. And we usually do this while we're walking to the scanner. Okay, is the patient awake or not? And you keep giving points. You do require a training, and such training, it's online, it's free. It takes a second. It's kind of annoying to do when you have to do it every year, but it's easy to do. You ask about consciousness. You always ask questions. Tell me your name, sir. How old are you? Check. And then if they follow commands, they need to perform commands. The gaze. Is it forced to one side? And are you able to call them to see you on the other side? The ones that are harder to do on these NIH is the visual fields, because the patient is moving. And if they're aphasic, how do you know if they're seeing you or not? Trying to sort of guess if they blink, for example, to threat. And you do it very, very fast. You see them if they move spontaneously and try to keep them up, and you give them the best score possible for their movements. What I do is I have them bring their arms up and I force them to keep their arms up, like, come on, up, 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 up. I'll do a detailed exam later on. And when you're thinking about the NIH, you give a number to all of this. You sum up the numbers. You can use MD Calc. I always use MD Calc, where I put in everything that I see to make sure I don't miss anything, which usually ataxia is the one that I miss. But I also make a special recognition to the cortical signs of a stroke, because in my patients having a cortical sign, it is very likely my patients having a big stroke, usually a large vessel occlusion. Here we have a scale that a lot of people can use, the FANG-D scale, and there are other acronyms for it. That is 90% specific, sensitive, not specific, sensitive, for detection of large vessel occlusions. And it's whether your patient has a field cut, if the patient has aphasia, if the patient has neglect, gaze deviation, or dense hemiplegia. They're extremely, extremely weak on one side. And on top of that, they're unable to talk, they're ignoring one side of the body, or the eyes are forced to the side that corresponds. Like the eyes are looking away from the weakness. Okay, if they're right-sided weakness, it's coming from the left side of the brain, and the eyes are looking to that left side of the brain. This is really important because seizures can look like that, but with one difference: the eyes look to the weakness. And that way, oh, my patient's probably having a seizure or is coming back from a seizure. So you may use this. This is one of the scales, and there are variations of this in many studies that have try to validate their sensitivity and specificity. But if you remember aphasia, neglect, and gaze deviation, those are the most important ones. Now, the MRS is the modifier ranking scale. This is our simple language that have all the studies have what all the studies have used to be able to characterize whether the patient had any recovery from the intervention that we've been doing. It is advisable to document what the patient's baseline is as they come into the hospital, because it's different to say, oh, my treatment worked on somebody that has severe disability or not. It's important to know also to see if I'm going to subject the patient to a risky procedure or not, and in the setting of a stroke. The MRS goes from 0 to 6. 6 is when they've died, and 0, no symptoms. And one important point of difference is MRS of 3, because that's when they start using devices to walk. Now, the MRS has the problem that is very dependent on the walking, and a lot of people can have semi or completely normal lives, and they're unable to walk. So there's a big caveat. So maybe somebody is wheelchair bound and they've been wheelchair bound since they were born, and they give them an MRS of 5, which makes no sense. That doesn't mean you're not going to treat that patient. If they lose another ability, you still need to treat them. Now, let's talk about stroke imaging. Once you evaluated your patient, you need to determine what type of imaging am I able to get for my patient, and what's the evidence behind of what I choose or don't choose. And I'll show you, this is my favorite one. This is the perfusion one. Now, we're still with the non-contrast CT. When am I going to get a CT angiogram, an MRI, and a CT perfusion, MRI perfusion, special emphasis on CT perfusion. I love this graph because it got cut off, but this graph shows you the circle of Willis, which almost never looks like that. It's almost never complete. But where do each stroke correspond according to the vascular territory? And these are the areas that are going to tell me, okay, my imaging looks like a stroke, or my imaging does not look like a stroke. This looks like something else. And in a lot of the times it can get missed and say, oh, the patient has a tumor. No, it's likely a stroke, just for a non-con CT. And we usually know all of these locations by heart. So let's start with the non-contrast CT. This is just a screening tool. A lot of patients like, oh, when I first started reading the CTs, what am I gonna do with this? I don't know. They look different one side or the other. How do I know something's abnormal? Well, it's not meant to be highly detailed. The CT is to rule out the big, scary things. And it has the highest sensitivity for hemorrhagic strokes, 86%, but really low for ischemic strokes, especially less than 10% when it comes to dizziness and vertigo. Because dizziness and vertigo can be something not as in like BPPH, like, well, what am I gonna do with that? It's like it'll go away. You'll be fine. It's annoying, but you'll be fine. Or it can be a basilar stroke. It can be very scary, but it has the lowest sensitivity and the lowest cost effectiveness when it comes to assessing these patients. Now, when we look at the head CT and ruling out the big important things on a patient, we want to look at 3 different things. Now, I'll show you the next slide, but is my patient having a bleed? On the left, you can see the patient's having a bleed. We have a hyperdensity here, it's growing. This patient's not going to get thrombolytics. Or my symptoms secondary to hydrocephalus. Look how the ventricles here look big. And I'm a neurointensivist, so this is where I get happy. But this is what I see the most in that neuro ICU. The ventricles are big. This is what the CT is going to help me the most. It's not going to tell me exactly, is it really a stroke? Is it not really a stroke? But when I'm looking for certain sort of subtle signs of a stroke, I see of hypodensity areas. Am I losing grade wide differentiation? Look, the grade actually looks white here, but am I losing this on an area that I'm suspicious of being responsible for the stroke? Is there a hyperdense MCA sign? And I'll show you what a hyperdense MCA sign is. Now you have a non-con head CT, and the next thing will be a CT angiogram. Now, the CT angiogram is the best sensitivity for detection of large vessel occlusions and the cervical anterior circulation. So if you're having somebody with a large NIH stroke scale, like NIH, it's above 6, above 12, usually these patients above 20, it's very sensitive to detect if it's obstructing the carotid. And it's a level 1 recommendation from the American guidelines. It has a negative predictive value above 97% for vessel stenosis over 50%. So if your carotid is 50% stenosed, you're gonna see it, or you're gonna rule it out. Now, the recommendation drops a little bit when it comes to intracranial arteries and posterior circulation, because there's not enough evidence that it will change the outcomes. Because what are you gonna do with it? And depending on the scenario, then I'll tell you why a little bit more detail later. Yes, if it's this artery here that you can see the arrow, that's the M1, you may take that patient for thrombectomy. But if you don't have thrombectomy in your hospital or in your country, like most countries in the world, then what's the usefulness of getting a CTA? Maybe for knowledge, but maybe a non-country CT will be enough. And that's where cost effectiveness come into play. Now, CTA has also been used to characterize the carotid plaques, and give a risk stratification, give them on stenosis, and some studies recently published looked at the calcification types of the plaque and divided it up to 6 types, and each type having more or less risks of obstructions, dissections, and more complications, so forth. Um, and then we do an MRI, which is this is how you make a neurologist fall in love. Just get an MRI, which is amazing. It's great. An MRI will tell me, okay, is this really a stroke or is it not really a stroke? An MRI detects a stroke in 20% of patients that have dizziness of vertigo. Remember, the CT is less than 10, so an MRI is going to be the way to go on those patients. An MRI has different sequences. I'll mention this here, the DWI, ADC, those are my stroke sequences. Then I go to FLAIR, SWI, or GRE. This is just the names that we use to be able to identify of the different filters. I call them the Instagram filters for each section of the brain, for the brain on different ways to identify, is my stroke acute, not acute, is it big, is it small, or is it really there? Because maybe it is not a stroke. But again, the cost. In a lot of places, we just don't have an MRI. I come from a small city in Ecuador where, I mean, good luck getting an MRI. And if you do, it's not going to be a good quality. I think recently they got new machines, but still. And these are the sequences you'll see. And here, this is an acute stroke. On your left side, you have a DWI. That's the first sequence that I go to as somebody that manages strokes, because it's going to be bright on my DWI, and it's going to be in a vessel territory. So look, this is the perfect MCA territory. This is my ADC, apparent deficient, and the ADC is going to be dark. And over here, it's a cerebral blood flow. It's going to show you how it's less here compared to the other side. So I know we're having an obstruction. Now, the CT perfusion. Now, this is my favorite, and I'm very biased because um, here at Stanford, that's where most of our studies have, a lot of the studies for CT perfusion have come from. The lab here of Greg Albers, and he works really closely with Rapid AI software for the detection for the use of CT perfusion and imaging modalities and the detection of strokes. So everything here is with CT perfusion. We've got it all the time, and I used to be like, oh, let's not get it, but now everybody gets a CT perfusion. And what this does is gives me a nice image of the penumbra of my stroke and the core. What areas can I salvage and what areas cannot be salvaged? And I use this not only for stroke, which is the actual indication, but I've used it in other patients that, for example, suffer arachnoid hemorrhages. Um, I don't know if it changes the outcomes there, but to try to identify vasospasm and other things. But what the CT perfusion does is a calculation of cerebral blood flow. so your blood volume, and the mean transit time, which is the time that it takes the blood to go through the capillaries in a particular area of the brain. Using Rapid is that's the name of the company. It's an AI detection of these abnormalities, and it gives you these pretty maps. But what the guidelines say is that you can use this if the symptom onset is above 6 hours. Um, Checking on time. Oh, I'll be a little bit faster. So we'll start with non-con head CT. We'll go to CTA, and then you may add or not the MRI and CT perfusion. Now, do we have this in everywhere? No. In a lot of places, maybe just a non-con head CT will do, and there's some evidence that that may suffice. Now, let me tell you about this case that I recently had. This was a 66-year-old man that was on atrial fibrillation and rivaroxaban, very compliant with his medicine, had a loud breathing, and the wife thought he was unresponsive, but he was just not moving. They even did some chest compressions because they had no idea what happened. And by 2 a.m., they saw him. 2:10, they were in the ED. And the patient had left-sided weakness. This is the scan. The non-con head CT was done in the ED, and they said, "Oh, you're probably having a seizure." But the patient was still weak, and an hour later, at around 3:30, the son was like, "No, something's wrong with my dad. He's still weak. He can't move the left side of his body." And I want you to pay attention to his eyes on the scan. You see over here, the eyes are deviated a little bit towards this side. And my patient has left-sided weakness, so it tells me, oh, my eyes need to go to the territory that will give me left-sided weakness, which is the right side of the brain. And if you imagine, this is what I'd say about CT, this is non-scientific at all, but if you imagine it, you'll see it. So if you imagine the patient's having a stroke on the right side, kind of see like it's kind of darker on the right side, and then you can't unsee it, and it's probably true. Um, and you keep going down and you find reasons why this patient's actually having a stroke. And I want you to take a look at this. This is my ICA inside this. This is the intracranial portion of the ICA as it joins the MCA. This is a clot. The clot is from here to here. But compared to the other side, this is a hyperdense MCA sign, ICA sign. And when we come to the CT angio, take a special look at this vessel over here. Look how the contrast keeps flowing. That area look not great, but keep looking at it. Keep looking at it, and it's gone. This scan was taken an hour and a half later because the son insisted. They anchored on that this was a seizure. This was a seizure. Look here. There's no contrast. There's contrast. The patient's having a huge occlusion, and he arrived within the window for TNK. Not that he was a candidate, but was not detected in time. And we got the call for the transfer of this patient an hour later after that. So there was a delay in 3 hours for the evaluation of the patient in a system where there are things that we can do. So, I mean, so once the patient arrived to Stanford, we usually get patients from a lot of places that are far away. The patient arrived about 3 hours later, and they go straight to MRI. We have a system in place where patients are rolled. We're waiting for him in the MRI scan, and we get fast pictures. We want to be able to take the patients that we know that are more likely to do well. Remember, I told you about DWI. DWI is the sequence that tells me a patient's having an acute stroke. This is my ADC. So this is an acute stroke on the MCA territory. It's the same pictures I showed you before. And this is the perfusion. The purple area is the core. It's the area that is not going to be salvageable, no matter what you do. And over here, the green is the penumbra. But you see how it matches? Once the patient arrived, there was nothing to be done. He was not a candidate for thrombectomy. So this is not a seizure. This is what happened to the patient 2 days later. Continue to develop. Look, the hypertense MCA signs a lot more remarkable here. There's evolving swelling. Look how the sulci are going away, and there's midline shift. The only way this patient can stay alive is with hypertonic therapy and decompressive hemicraniectomy, which he got. And the second case, which also this is my bad. This is a patient that 59 has lupus and bipolar disorder and migraines, have a couple of admissions with this weird dizziness that can't walk and super dramatic and so all over weak. And there's usually this left-sided kind of weakness, but it's mostly like unstable. We saw her DNH was 5 and it was giving away like a giveaway weakness. And we call that when patients having a functional disorder. We got the scans, we got the imaging, and this is what it showed on the left side of the cerebellum. There's some perfusion delay there. This Tmax 6, it tells me is the let's say the penumbra in that area, which is weird. It kind of correlates. When you're having cerebellar strokes, these ones from this territory, it's ipsilateral symptoms. Keep looking at the maps because we looked at everything. Doesn't make sense. It can be artifact too. Up to 20% of the CT perfusions, 20 to 40%, they have artifacts or they're not done properly. And keep looking at all of the numbers to see if it makes sense. It kind of looks like more delayed here, like blood is not getting here the way it's supposed to be getting here. And here, the patient had a stroke. We did an MRI later and had a stroke. She was within the window, so she got her TPA, and she did better. Now, when do we give TNK and when do we do mechanical thrombectomy? I think I have like 10 minutes. So this is IV thrombolysis, and it's best if it's given within 60 minutes. That's the golden hour for TPA TNK. Now, TPA is the initial medicine that was approved with the NIMS trial and the ECAS-2 trial, and it was on the 1990s. Uh, and now we use TNK, which is faster to use. It's just one bolus. It used to be cheaper, but I think they're matched. And it's more fibrin specific, so it has a superior clot lysis. Um, but the problem with this is that not everybody's getting it because it's expensive. Here in the US, up to 12% of patients that can get TNK is getting it. A lot of it is because patients just don't go to the hospitals and they don't go to hospitals enough with time. So at the beginning with the NIMS trial and ECAS-2 trial, we said, yeah, they have to be in the hospital within 3 hours. But now with the ECAS-3 trial, the patients can get TNK within 4.5 hours. And this is huge because it's going to be night and day for patients in a lot of in a lot of the cases. You know what the number needed to treat for TPA is for strokes? It's going to be 3.6 within the first hour. The number needed to treat for STEMIs, like 45. So it's amazing. This is like night and day for patients. And recent studies that have come out from here, from Stanford, we have the Timeless trial that said, okay, if we use it up to 4.5 hours, what happens if we use it up to 24 hours? Maybe not thinking much about the timing of things, but about the perfusion imaging. And well, it didn't change much, but it didn't hurt people. So for certain patients, if you're a little bit more than that, it's not going to hurt them. Now, the indications have changed with time, and this is where I want to make the emphasis is like it used to be within 3 hours, and that's what the FDA still says. But we can use up to 4.5 hours. And in some wake-up strokes, we use an extended window where we can use it up to 9 hours later, but using MRI and perfusion data. And sometimes we do this in patients that before they get transferred. They need to be above 18 years old. Unfortunately, kids are not enrolled in trials, although they're trying to make that happen. And FDA gives a warning for patients above 77 years old, but any age is fine. They can get TNK as long as they have a disability. There's kind of like significant disability on these patients, and you're kind of sure they're having a stroke. You don't want to use it, and you can. All of these is straightforward. You want to make sure you rule out all of the other things. But remember, if the patient's taking aspirin, if they're taking Plavix, they can get TNK. They can get TPA. And special considerations. If they're rapidly improving neurological symptoms, sometimes patients don't give TNK, but that's not the recommendation. If those symptoms are disabling enough, go ahead, you can do it. Now, how about if the NIH is 5 or less, which we'll call this the slow stroke scale strokes? Well, recent studies, the PRISM study and the RAM studies showed that using just aspirin, for example, in PRISM, and RAM is a DAPT, aspirin and Plavix, was the same as using the TPA for these patients, but less risk of bleeding. So in those patients that are not that have the low NIH stroke scale, that's why it's so important for you to calculate it. You can just load them with aspirin and Plavix. It's cheaper and a lot more accessible. Use it in patients that are above 80 years old. Do not use it in an aortic dissection. It's not stipulated contraindications. I've had 3 patients already that have died on the table. I was about to give TNK, but I got the CT angio just to make this faster, and we saw the aortic dissection. Did not get the TNK. And in patients that are using factor 10A inhibitors, if your patients are using Eliquis, well, a lot of patients don't take their medicines. So check an anti-10A level if you have it, or confirm if that patient is actually taking the medicine. When was the last time they took their dose? If it's over 2 days, give it. Patients that are on warfarin, check an INR. If the INR is less than 1.6, give TNK, TPA. It could be night and day for these patients. And about mechanical thrombectomy, back in the 90s, even like in the beginning of the 2000s, mechanical thrombectomy was terrible. It was causing a lot of bleeds. And even up to 2013, the trials were neutral. But starting 2015, they they became positive because they changed the devices that they were using on. Before it was like basically a plunger, but now we're using very tiny devices that are able to take out the clots. So up to 2018, now we have the huge trials, the Dawn and Diffuse trial, which they said, okay, in 2015, you said I can use thrombectomy up to 6 hours. Well, we can use up to 24 hours. And nowadays, we're using to the thrombectomy in some patients using CT perfusion for a little bit more than 24 hours, which still it's understudied. But special considerations, when it comes to basilar occlusions, there's not great evidence that it actually works. We do have 2 positive trials, the Bausch and Attention trial, that says that if done, it's good, it improves the outcomes, but not as great because there's certain patients that benefit from the thrombectomy compared to others. If it's a huge clot in the middle of the basilar and you take it out, patients do great. It's amazing. But sometimes they have so much atherosclerosis that even if you go in and take out a clot, they reocclude, and that doesn't make much difference, making these trials hard to do. The next one will be the distal occlusions, and the recent trial just came out, the distal trial. Um, these distal occlusions mean small MCA artery occlusions. Those the evidence is not great of going after those. The vessels are small, the definitions are not great. So what's your small vessel? I don't know. For me, it's a different small vessel. And the large core trials. And that's where a big emphasis is coming to, because we want to get thrombectomy to the most patients as possible. And it was a huge topic of discussion for the last year. These are all the trials that have been published for large trials. And we say large core because these patients have um, already a bigger size, on the bigger side, like about 70 cc's of volume of core, of dead tissue on the CT. It like looks like it's dead. Um, and that's a random determination. And want to say, okay, why, like, what's the cutoff? Like, when do I take the patients for thrombectomies or not? A lot of places are taking everyone. Come on, let's get thrombectomized. But then they bleed and die. So why are we subjecting people to procedures if we don't have evidence for it? At Stanford, we're doing a randomized control trial on for everybody that has a large core. Um, to try to tell me, okay, what's the cutoff of the volume? Because here the cutoff of the volumes in the large core trials are still not, they're big, but maybe not that big. Maybe Lastic has a little bit bigger sizes, but anyway. But let me tell you about this case 3. This recently came to the hospital, a 68-year-old. They came in with an NIH of 14. Suddenly collapsed, right gaze deviation. Look, has a hypodensity here. But this is really important because one of the contraindications, they recently had a stroke. This stroke is definitely not recent. So this patient got TNK. This is what the Rapid AI app showed me. There's an occlusion here. You don't have to be an expert. You just look at it and say, oh, dang, there's an occlusion. Just tell you there's an occlusion and I need to call for help. They gave TNK and they transferred to Stanford. As soon as the patient got to Stanford, this is the perfusion map. You can see this green area is the is the penumbra, and this is the core. This patient was probably a good candidate for thrombectomy, although it's a distal occlusion, so not great. But they got to Stanford and the vessel opened because they got TNK, no need for procedure, and it's because we were able to do an MRI on arrival. Now, so what do we do for stroke prevention on these patients? The most common one that everybody knows is the cardioembolic strokes. You want to get an EKG and long-term monitoring on these patients. Everybody should get an EKG on arrival. Absolutely everyone. You don't need to get them on telemetry on their whole admission, but they should be monitored as an outpatient. The Stroke AF trial evaluated these patients with long-term monitoring for 12 months, and they found that it was a 12% higher incidence of AFib discovered during those 12 months. And if you have a stroke in AFib, that's it, you're getting anticoagulated. You want to get cardiac imaging, an echo with bubble study, if possible, not necessarily in patients that you don't have an etiology. If your patient has AFib and a stroke, I mean, don't get the echo unless they're a heart failure. That's it. That's all you need. But if it looks like they have cardioembolic strokes, like here, like bing, bing, bing in multiple territories, this is not just MCA, like this is some PCA, you want to be able to get an echo because there's like showering clots from somewhere. You want to see if there's the cardiopathy, foraminal valley. So in atrial fibrillation, if it's a non-valvular AFib, use DOAC. There are 6 trials that are already proved the non-inferiority of the DOACs with warfarin. No need to subject people to warfarin if they can afford the DOAC, of course. How about the valvular AFib? There are 3 trials or more that showed that they are not superior to warfarin. Unfortunately, Xarelto was shown that it increases thromboembolic events in patients with mechanical valves. So those patients unfortunately stuck with warfarin. And then what if your patient just bleeds? They have multiple GI bleeds. They're bleeding and bleeding and bleeding, and they're not candidate for anticoagulation. Recent trials like the Prevail, Protect AF, PROC 17, and the Amulet, I think is about to come out or already did, uh, about the left atrial appendage procedures, but they block the area where the clots may be formed. And we have some patients that do get them. It's not the best, it's not ideal, but it helps prevent strokes and disability long term. And PFO in cardioembolic strokes, this is where your rope score comes into place. And by rope, go to MDCalc and you calculate it, and it gives you the probability that the stroke of this patient or young patient was because of that PFO. Now, your patient has AFib, has multiple strokes. When do I start my Eliquis? We have here the ELAN trial. It was published in 2023 and evaluated when it will be a right time for start anticoagulation. What was I doing up until then? Eyeballing the size of the stroke, and if it's small, go ahead, start it. If it's not small, it's big, maybe wait a few days. But basically, this told us that if it's small and medium, gave us evidence that yeah, just go ahead and start it. You can just go ahead and start the Eliquis on patients that have small strokes, and it should be fine. Some patients may have a small bleed in the area of the stroke, but then it goes away, and not that we find it in any way. If it's a bigger stroke, before people used to wait 2 weeks, but they can restroke. That's when the high stroke rate is. So they will now you can start like up to 5 days or so. Other causes of stroke that are common, small vessel disease. It's like 20 to 30% of our strokes. And for this one, the most important thing is to manage your comorbidities. That's it. Control the blood pressure. Keep them lower than 132 over 80. You don't need to drop them super fast. You can drop them with time because then there's other complications, the diabetes, the hyperlipidemia. But we all know this. This is not new. What we do emphasize on, if the patient has one of these strokes or any form of stroke with a low NIHSS, less than 6, then we use that, Plavix and aspirin for 3 weeks and lifelong aspirin. There's no evidence for any of the strokes if the NIH has been higher on admission. It has to be on admission that that it will benefit them. Other stroke etiologies, ESIS, embolic stroke of unknown source. People come with strokes and we don't know Where are they coming from? That's why we keep the Holter, the monitor. We keep monitoring with time. Intracranial atherosclerotic disease. Look at this basilar. This is supposed to be a basilar. There's a lot of atherosclerosis there. Sickle cell disease. Extremely important sickle cell disease. If a patient has a stroke and sickle cell, transfusion therapy. That's all you need to do. Well, the most important thing you need to do. If they have septic emboli, if your patient has infective endocarditis, don't worry about aspirins, anticoagulation, those things. Patient needs to be treated for the septic emboli. You don't need to commit them for lifelong aspirin. It's fine. In hypercoagulable states, cancer, we don't really know about strokes that are related to cancer, how to do a secondary prevention. Maybe aspirin's a little bit better than anticoagulation. We've tried both, but recent studies haven't proven that one is superior to the other. And vasculitis, those are the weird. But in general, most strokes, a good chunk of strokes are cryptogenic. We just don't find them, and they need to keep being followed by neurologists. Now, complications of a stroke, I showed you the one before. Brain edema is the big one. It's the large territory strokes, and this is the one that's going to kill the patients, as well as infections. Patients can't swallow after a stroke. It will get better. In most patients, it will get better. But in the immediate phase, they have increased secretions, aspirate, and they can die. So these patients need to be monitored closely in a hospital, especially if it's a large stroke. If there's brain edema, they need to be in an ICU. The swelling will be the greatest in the first 3 to 5 days, and they need surgical decompression if that's within their goals of care to preserve life. Our patient that I showed you before, and the right-sided stroke, got the decompression, and eventually, I think he'll do better. He'll do fine. I don't know if he'll walk again, but they do well. Now, I want to end up with where the future of inpatient stroke care is. And this is a map of the access to mechanical thrombectomy in the world. I think that that's where the future is. Access to mechanical thrombectomy in the world. I told you about CT perfusion. I told you about Alto. I told you about all of these fancy terms that I'm sure most people will forgot. um, and what does it make sense? Like, if I have all these fancy terms, if in Ecuador, if in Bahamas, and in a lot of places, I just don't have mechanical thrombectomy. I think the research needs to focus there. Now, but if we want to be more scientific about where the research will go, is maybe we don't need a time-based selection of patients. Maybe we need imaging-based selection. What if my patient that comes in a day later, I do scans and they're candidates for thrombectomy? Which let's do it. Maybe a combined approach. Maybe I won't give you systemic thrombolysis, but a combination of mechanical thrombectomy and intra-arterial thrombolysis, like tiny amounts of TPA in the small arteries, that we avoid systemic complications. Maybe the use of intracranial stents. They're making a comeback. Sam Pistral several years ago said, no, don't do it. But if it is experienced provider, maybe that's what we need. And maybe a personalized care, thinking of a cerebral autoregulation of patients that are in the ICU to improve their outcomes. Mission thrombectomy is where I think the future is, to be able to access thrombectomy all around the world. And it happens to be that tomorrow is the World Stroke Thrombectomy Day. So it's great timing. Thank you very much. And I'm open for questions.
Thank you. Thank you so much, Dr. Franco, for quite an extensive and informative talk. We do greatly appreciate it. I'm sure that many of our healthcare colleagues on the call are currently thinking of their questions and comments for you. And as they do that, I just want to remind everyone on the call, this is a accredited presentation. So kindly ensure that your name reflects the name that you are registered in at the Bahamas Medical Council. Please fill out your form for this presentation. That is also going to be needed in order to collect your credits. The floor is now open for you to ask questions, to make comments to Dr. Franco. see everyone is still deeply pondering. Do we have any questions?
Yeah, there's a lot of information in one. Maybe we can start by sharing your experiences, how stroke care has been, or the areas of doubt in your region. That would be interesting.
Okay, we had a question pop up
Oh,
in the
good.
chat. When is it too late to send a patient into the ER after stroke symptoms?
That's a really good question because what does too late mean? Is it because the patient's already dying, or is it because the symptoms have already improved? Now, if the patient's already dying, I would argue that we don't know if they're dying from the stroke. And we don't know if that by going to the hospital, we'll be able to save their life. And that's what they would want. If it's somebody that you know that would like the medical care to be able to survive this by a craniectomy, and that's something that's available, then I would argue take them to the hospital. And even take them to the hospital regardless, because everybody deserves a comfortable death. And that's something that can be provided in a hospital, depending on the system, of course. But if it's somebody that tells you, oh, yeah, 2 weeks ago I stopped moving my left arm, but that's fine because I'm right-handed. Mm, I would say go get a scan if possible, but if somebody that can't afford it, it needs a detailed evaluation because it's likely ischemic stroke. And if even if it's hemorrhagic, maybe you should start some secondary stroke prevention. A lot of people can't afford a hospital, so just some studies have shown that it could be safe to just start aspirin and modify some of the risk factors without the need of going to the hospital or getting scans.
Okay, thank you. We have another question. Can you elaborate again on contraindications to thrombolysis in those who arrive within the window period?
Yes. So when the most important thing is that they're within the window, which is 4.5 hours, even if the FDA just says 3 hours, it's 4.5 hours. That's what we use. If they're above 18 years old, and even if and the wake up strokes, don't we shouldn't think about that because it's hard to get an MRI in the ED in most places. But if the patient had a severe trauma in the past 3 months, anything that will make the patient prone to bleed, think about platelets. Less than 100,000, don't do it. INR above 1.6, you don't need to check it before you give it. But you do draw the labs before going to a scanner, and it'll tell you if the INR is elevated or not. Or patients take warfarin, you would know. Previous ICH, if somebody has had a brain bleed ever, you can give it. That's it. No more, no more, no more TPA ever. And if they have infective endocarditis, they can be common. Now, the patients with sickle cell, there's no evidence you cannot give it, but I would give it if there are no other of the other contraindications.
Okay, we have another comment and question. Thank you for this presentation and your updates. Considering all of the research and information available, where would you say is the best resource for algorithms for the management of patients with stroke?
I think the best resource that I found is the American Heart Association guidelines that were published in 2019. They have a summary of the algorithms and also presentations where it shows like a simplified form of what's the evidence of what to do with these patients. I usually go there when I have certain doubts.
Okay, thank you. Is there any app for patients or a toolkit for general physicians to recognize stroke at its earliest?
Not that I know of. It is an interesting thought. What we do have is the Rapid AI app, but that's not available for everyone. That's usually an institutional thing, and I bet it's going to be expensive. Um, I haven't heard of any apps.
You. Excellent presentation. What can we do as healthcare providers to advocate for increased access to mechanical thrombectomy in low resource settings?
I love that. I love that question because that's what I'm gonna dedicate my life to. So what can we do? Is raise we I think that we can start by raising awareness to our patients. The more patients we identify with strokes, the more impact they make to a healthcare system, and the more information we have for the stakeholders to use and say, hey, I had 150 patients here coming for strokes. We need thrombectomy now. We need somebody that be able to do thrombectomy. In your case, maybe advocate for the transportation of patients to the nearest thrombectomy sites. I know that some areas in the Caribbean they transport to the US for the thrombectomy. Maybe that would be it. But the other thing is like, do you have cardiologists that can do the thrombectomies for the heart? Teach them how to do the ones for the brain. Interventional radiologists, those can also learn how to do aspiration thrombectomy because it's actually it's not that difficult. Once if they know how to do it in the heart, they can just sweep the cap to the brain. But it's a lifelong process, and for hospitals to be able to affiliate with Mission Thrombectomy, I think that it comes with a united front worldwide to gain access to be able to close the gap for patients. But please ask me that again in 30 years and see how we do. I'm hoping to be able to do that in my country.
Thank you. Is there any indication for DAPT beyond 21 days?
Yes, if your patient has intracranial atherosclerotic disease and that you believe that's the reason for their stroke, we use that for up to 3 months, 1 to 3 months, and basically we look at the CTA and there's a lot of plaque everywhere. We that's what we use. Or if there's a lot of plaque in the exact vessel inside the brain that is responsible for the stroke.
Thank you. Thank you for such an informative presentation. The cases and trials truly drove home where management will be going in the future. I look forward to our public hospital acquiring an MRI and the country mechanical thrombectomy. And we
That's
have
amazing.
another comment and question. Thank you for your presentation. Excellent job. In your experience, what was the most unusual presentation of stroke you saw?
The most unusual, I keep changing them. Um, I keep having different ones, but I would say that the most uncommon ones would be the ones that present with seizures, and you treat them as seizures, and then they are unresponsive. The one that I did see recently, now that I remember, a 35-year-old with a cardiac arrest, had difficulty breathing, had a cardiac arrest, so went into the whole shebang of resuscitation, and we get consulted after for prognostication. And we said, okay, let's get some imaging, and turns out that the basilar was completely occluded and it was already too late. That's expected for the basilar, but we don't see it that common. Like you say, yeah, basilar occludes, then you get into a discoma. But for it to come with cardiac arrest is kind of rare, but it can happen.
That is interesting indeed. Do we have any other questions or comments for Dr. Franco? I'm not seeing any other oh,
Thank
great
you.
presentation. Right in under the buzzer. So, with that, I would like to once again thank you, Dr. Franco, for taking time out of your schedule, very busy, I'm sure, to provide us with this wonderful education. It was a beautiful learning opportunity. And I know that our physicians will take the information that you provided and incorporate it into their daily clinical practice. And I want to say thank you for attending. And I hope that you have found it quite useful. I'm sure that you did. And I just want to once again remind you to ensure that you complete the survey for this presentation so that you can achieve your required amount of credits for the Bahamas Medical Council. And the last thing I want to say is a very special shout out to all of the family physicians who will be celebrating World Family Doctor Day next week. Um, Monday, May 19th is the actual day, but the celebrations will start from Sunday and go through until Saturday. So, a very special, happy World Family Doctor Day. So, with that, we bring this CME to a close. Thank you, everyone, for attending, and we will see you at our next CME, the last Friday of this month. Have a great day.
Thank you.